So, I think we have just talked about ALK. Now we talk about BRAF. We all do a lot of NGS now for lung cancer. That's very common. And we do find a few BRAF mutations here and there. Although the frequency is not that much, but we still do find. So, how do we treat BRAF mutation? Positive lung cancer, that's what the next few 10-15 minutes we will discuss that. Once I get the slides rolling. So, let's see. Yeah. So the objectives of this talk, one is to understand the role of BRAF in metastatic non-small cell lung cancer. Second is to gain awareness of BRAF testing methods in the diagnosis of BRAF positive non-small cell lung cancer. And third is to review the clinical data of dabrafenib and trametinib in advanced non-small cell lung cancer. So introduction to BRAF. The RAS-RAF MAPK pathway plays a key role in cell proliferation, and BRAF mutation result in BRAF activation and uncontrolled signaling via the MAPK pathway. BRAF mutations now occur normally in 1 to 4% of all non-small cell adenocarcinomas. I think on an average about 2 to 3%. So it's not that frequent, but yes, we can find and we can treat them appropriately. They do not overlap with other common mutations like KRAS, EGFR, ALK. And key patient characteristics or indicators for BRAF non-small cell lung cancer have not been well characterized. But some studies have shown that patients with BRAF mutations are more likely to be female or have a history of smoking. The commonest BRAF mutation in non-small cell lung cancer is BRAF V600E, occurs about 50 to 70% of all BRAF mutant positive cases. The others are very rare, and we don't know the significance of those mutations and whether to treat them differently or not. So BRAF V600E is the most important and common mutation, BRAF mutation in non-small cell lung cancer. The other mutations have been identified, as I discussed earlier, but we don't know the clinical significance. The other mutations like BRAF V600L, G469A, W604R, they can occur, but the frequency is much less, and also we don't know the clinical significance. So what clinical significance does the BRAF mutation have? So if you have a BRAF V600E mutation, the most important is the prognosis is poor. They have got a shorter median DFS and OS than patients without the V600E mutations. And you can see the Kaplan-Meier curve show that the disease-free survival and the overall survival are significantly poor as compared to non-BRAF mutant positive individuals. Also, the outcome of patients with BRAF mutant cases with chemotherapy is again poor. So if you take platinum-based chemotherapy, which is standard of care, the PFS for BRAF V600E mutant population is much worse than the wild-type population. The response rate is 29% versus 48%, median PFS 4.1 months versus 6.7 months, and the median OS is 10.8 months versus 15.9 months. So BRAF V600E, poor prognosis, and also it is poor response to chemotherapy. The problem with BRAF mutation is that approximately 1/3 of patients remain untreated. They receive best supportive care in the first line, and in the second line, 57% receive best supportive care. This was before the advent of BRAF inhibitors. Patients identified with driver mutation not receiving target therapy lived 1 year shorter than those which were identified and received target therapy. So that is why in targetable mutations, if you have a target therapy given, that is much better than not being given. This is the current schema of patients with metastatic non-small cell lung cancer, which are without ALK mutated, EGFR mutated, or ROS mutated. So we see that their prognosis is not that great. And if you can find a BRAF mutation, that's why the main indication for us is to do broad molecular profiling, so that we can then identify some other targeted mutations which are rare, but we can find them and we can treat them accordingly. So that is why all the guidelines, the ESMO, the NCCN guidelines, all of them suggest that we should look for all targeted mutations, whichever possible, by doing a broad molecular NGS. Upfront BRAF testing is needed to quickly and efficiently identify patients because BRAF, does not appear to correlate with any clinical risk factor like age, sex, smoking. So we don't know whether this patient is BRAF positive or not. BRAF positive non-small cell lung are more aggressive and a poor response to chemotherapy, and more importantly, that if we can find and we can target the BRAF mutations, then we get a better response. So coming on to the clinical data of dabrafenib and trametinib. Dabrafenib is a reversible potent inhibitor of RAF kinases, and trametinib inhibits a MEK1 and MEK2 kinase activity. And this combination is supposed to be better than giving dabrafenib alone. And that is why the current approved indication for BRAF V600 mutant population is to use a combination of dabrafenib and trametinib. Again, this is there's a rationale for combination of both the drugs because they work synergistically inhibiting the MAPK pathway, and therefore the response is better than giving dabrafenib alone. This is a phase 2 study of dabrafenib plus trametinib in BRAF mutant, V600 mutant non-small cell lung cancer. I think this is the most important study in this setting, and this got 3 cohorts. The cohort A is a pre-treated and monotherapy, giving only dabrafenib 150 milligrams twice a day, and 78 patients. Cohort B is patients who have been pre-treated and now they are receiving combination of dabrafenib and trametinib. And cohort C is the treatment-naive patients who are just receiving the combination dabrafenib and trametinib, 36 patients. The primary endpoint was response rate, and the second endpoint was PFS, duration of response, overall survival, and safety. Look at the cohort A. If you look at the baseline characteristics, 2/3 of patients in cohort A, that is pre-treated and receiving single agent, were current or former smokers. Nearly all patients had adenocarcinoma, and almost half the patients were in second line and beyond. The cohort B, nearly all patients had adenocarcinoma, 3/4 were current or former smokers, and 1/3 of patients had received more than 2 previous lines of chemotherapy. And if you look at the treatment-naive patients, the cohort C, all patients had adenocarcinoma histology. So one thing is clear, that BRAF patients, we are looking at adenocarcinoma, not squamous. This is the summary of treatment study design which we already discussed. Cohort A, cohort B, cohort C. Majority of patients are adenocarcinoma. Now coming on to the efficacy results. If you look at cohort A, which was pre-treated and single agent dabrafenib, the partial response was 33%, stable disease 24%, and a disease control rate of 58%. The duration of response was 9.6 months, and median PFS was 5.5 months with a median OS of 12.7 months. Coming on to cohort B, where the patients are pre-treated and received a combination of dabrafenib and trametinib. Again here, the overall response rate was 63%. Disease control rate was 75%, and the duration of response was 9 months. So that is significant that even in pre-treated patients, if you have a combination of dabrafenib and trametinib, you still get a disease control rate of about 75%. The majority of patients in cohort B experienced tumor shrinkage. Response rate 63%, and majority of them had tumor shrinkage. The median duration of response was 9 months in previously treated patients. And also in the median PFS also was 9 months for the pre-treated patients. Coming on to the cohort C, where patients were treatment naive and they had a combination of dabrafenib and trametinib. And again, the response rate was in the region of about 64%. The duration of response was the disease control rate was 72%, and the duration of response was 15.2 months median. Again, majority of patients had a good tumor shrinkage, 64% patients had response rates. The median duration of response was 10.4 months in previously untreated patients. So what I gathered is that patients who were pre-treated and patients who were treatment naive, the efficacy results were sort of similar in the combination of dabrafenib and trametinib in both the cohorts. Coming on to the safety results, I think the most commonest problem which we face when using dabrafenib and trametinib is pyrexia. The second is asthenia, hyperkeratosis, decreased appetite. But these can be, managed with maybe slight dose reductions And I think over a period of time, these patients do tolerate these treatments better. And that's what we see with most of the target therapies. Nearly all the patients experience more than one adverse events, and almost half at a grade 3-4 AE. But there was a low discontinuation rate due to AEs because they were managed quite well. Pyrexia was the most common adverse event, 64%. Only 2% had grade 3 pyrexia. And I think the most important here is how to manage these side effects. So you can interrupt treatment if the patient's temperature is more than 38.5. You can initiate antipyretics. You can consider oral corticosteroids also in which the patient's antibiotics are insufficient. And then obviously dose reduction can be done. So the starting dose normally of dabrafenib is 150 milligrams twice a day, which can be reduced to 100 milligrams twice a day or 50 milligrams twice a day. And with paving is 2 milligrams once daily, and then maybe 1.5 and 1 milligrams daily. But what I've noticed in clinical practice is that even if you reduce the dose, the efficacy still remains. So a lot of patients on 100 milligrams twice daily are still able to perform quite well as 150 milligrams twice daily. It should be taken without food, at least 1 hour before or 2 hours after meal. In the summary, the safety profile of dabrafenib and trabectedin was manageable and similar to that previously reported in melanoma studies. The most common was pyrexia, GI toxins like nausea, vomiting, and skin reactions. But they can be easily and effectively managed. So I think that's from my side in this talk. And what I feel is that's again important. The key messages is obviously to NGS, we can identify 2 to 3% of patients who have got BRAF, V6 and mutation positive. And we've got effective treatment, dabrafenib trabectedin combination with an effective as well as manageable safety profile. Thank you very much.